So I'm going to talk about some immune modulating agents in the perioperative period. One, we get all concerned about our patients on glucocorticoid, and there's good reason to be concerned about it. We think about the risk of surgical site infections. We think about the risks of hemodynamic instability, particularly, is my patient going to have adrenal insufficiency because they are on glucocorticoids? And that's the thing we mostly talk about. But then there are the other long-term issues that come with glucocorticoids, your increased friability of your skin, your increased risks of fractures and GI hemorrhage and ulcers if you've been on it for a while, the impaired wound healing, the hyperglycemia that can happen, hypertension, fluid retention, all those sorts of things that can happen by being on glucocorticoids. I put this up just to remind us that really the biggest issue with the exogenous glucocorticoid is the negative feedback that it has on the hypothalamus and the pituitary, which then decrease the secretion of ACTH and decrease the production, physiologic production of your cortisol from your adrenal glands, right? So you're giving someone a lot of glucocorticoids, your body doesn't need to make it anymore. And if you then withdraw those glucocorticoids, your body is not able to respond as quickly as you would like it to. And then that can result in the hemodynamic instability we all worry about with glucocorticoids. So what are the specific risk factors we're looking for patients who might develop adrenal insufficiency from exogenous use of glucocorticoids? Well, if they're getting it systemically, right? They're taking oral treatments. They are getting long-acting glucocorticoids, which also can include the shots of glucocorticoids that you get in knees and hips for pain. Those are typically pretty long-acting. Higher doses of glucocorticoids, longer duration of therapy, really important. Cushingoid features, that tells you the patient's getting a lot of glucocorticoids. Higher potency medications, nighttime administration seems to make a difference. Multiple cycles, and this is sometimes where we get into trouble because the patient doesn't come in on glucocorticoids, but they've had multiple cycles of glucocorticoids over the years for their asthma or for their pain or whatever it might be that they've been getting glucocorticoids for, and you don't know about it if you don't ask whether they've gotten any glucocorticoids over the last year. Again, multiple daily doses. And then if someone stops it because they think they're going to do themselves benefit by getting off the glucocorticoid because they're worried about what it might do when they go to surgery. So how do we think about someone's HPA access when they are taking glucocorticoids? Well, first of all, you are not suppressed. Your HPA axis is not suppressed if you are taking just physiologic doses, no matter how long you've been taking the physiologic doses. So if you are less than 5 milligrams a day, you are not suppressed. If you are taking higher doses than that, you are getting your patient is getting some sort of steroid burst, say for their asthma exacerbation or their COPD exacerbation, but they are on that for less than 4 weeks, they are not suppressed. Now, if they are doing this multiple times through the year, you might need to think about it. But if it is one time, less than 4 weeks, they are not suppressed. Who is suppressed? Who is suppressed? And we don't even need to think about testing. The person who is getting greater than 5 milligrams of corticosteroid, prednisone, whatever it may be, more than 4 weeks. So greater than 5 milligrams for more than 4 weeks, you are suppressed. We do not need to evaluate you further. You are suppressed, and we will treat you as though you are suppressed. And then there is everybody else, particularly those patients who have been getting multiple cycles. You're not sure how much steroid they've gotten in the year. You're a little concerned about that. Or the person who decided to wean off their steroid, and you're not sure their adrenal gland is working quite right. So what do? You can test that HPA axis. You can check their cortisol, their morning cortisol between 7 and 9 a.m. to see what it is. If it is high, basically greater than 10, you're good to go. They're making enough cortisol, don't worry about it. If it is low, that tells you they are suppressed, less than 3, Nothing you need to do more to evaluate it. They are suppressed, and you should treat them like they're suppressed. If they are 3 to 10, you don't know. And that's when you start doing the cosentropin stim test, the ACTH stim test, where you give them the cosentropin, you then check to see where they are 30 minutes later. You do not need to get a baseline. You already got your baseline when you did the morning. You know that they had not enough cortisol being created. It was only 3 to 10, so you don't need to get a baseline. All you need to do is get a test 30 minutes into it. If they are greater than 14, they are producing enough. They are not suppressed. If they are less than 14, then they are suppressed, and you need to treat them as though they are suppressed. And you can assume the patient, if they are high risk, if the timing of the surgery doesn't allow you for testing. So you're not sure, you're wondering if they're high risk, you don't have a chance to test, just treat them as though they're high risk. Now, it is still very, very, very uncommon for these patients to actually have adrenal insufficiency and to get into trouble. But despite that, we have recommendations, and it varies from author to author, but they're all pretty much similar on exactly how much steroid you will give patients. Part of it depends on what is the specific risk of that surgery that they are having. Is it a low-risk surgery, minor? Is it a moderate grade 2, or is it major grade 3? You can see some of the different surgeries there that will constitute low, moderate, and major. Basically, major are any major orthopedic, spinal, oropharyngeal, or genitourinary repairs, and your, of course, intracranial, vascular, or cardiothoracic procedures. And then this is the recommendations from Dr. Salvatore and colleagues. Dr. Salvatore is with us at Hopkins, one of our endocrinologists, that they produced to say what you should be on if you're giving glucocorticoids because you are worried that their HPA axis is suppressed. If it is minor, if you think they're suppressed and they're only having minor surgery, then just give the 25 milligrams of hydrocortisone. Then you can start their regular steroids after that. If you think that they are suppressed and they are going for moderate surgery, then you're giving 25 to 50 of IV hydrocortisone at induction of the surgery, and then 15 to 25 every 6 hours until they are on PO, and then they can go back to their regular steroids. And if it is major surgery, then you're giving 50 up front, 25 every 6 hours, until they are hemodynamically stable, and then 15 milligrams IV every 6 hours until they are tolerating PO. And then you put them back on the regular steroid dose. Okay? So that's if you think that they are suppressed by either the history you got or you tested them and they came out to be suppressed, or you didn't get a chance to test them and you're still worried, and then you decide based on how severe the surgery is going to be, how much hydrocortisone to give them. Now, interestingly enough, the 2022 rheumatology guidelines say for patients with RA, ankylosing spondylitis, psoriatic arthritis, or SLE undergoing a knee or hip arthroplasty who are on glucocorticoids, continuing their current dose rather than administering supraphysiologic doses on the day of surgery is conditionally recommended. So the rheumatologists aren't buying that you need to give supraphysiologic dosing. You can decide what you want to do. How about with our DMARDs? So these are our disease-modifying anti-rheumatic drugs. We have two different types, the non-biologics, which many of your patients with rheumatologic disorders are on, or most of them. Those are things like methotrexate, Plaquenil, sulfasalazine. The data generally suggests that these are medications you can give without having to worry about stopping them, that they are not going to cause impaired wound healing, and that they are getting benefit by being on their medication, so that the benefit of being on their medication is definitely better than the harm that may come from continuing their medication. And so most of the organizations say that you should continue your home dose of non-biologic DMARDs throughout the perioperative period. How about the biologic DMARDs? These are things like your TNF-alpha inhibitors, your interleukin inhibitors like anakinra, your anti-CTLA4 for rheumatoid arthritis, or your B-cell inhibitors like Rituxan. What do we do with these? Well, and there are a lot of patients who are getting these. About 44% of patients with rheumatoid arthritis get a biologic DMARD. It is worrisome when the patients are on these medications. RA patients are at a 50 to 80% greater risk of periprosthetic joint infection when compared to patients who are on who have OA, osteoarthritis, and not getting these medications and going for the same sorts of surgery. There is impaired wound healing, and then you worry about the immunosuppression of, like you would all the time, that they could get other infections, viral infections, bacterial infections, TB, tuberculosis, fungal infections, and then combining the DMARDs with other medications might make their risk even higher. Now, what's interesting is the recommendations say elective surgery, you should hold one dose and then restart it probably about 2 weeks later as they are getting through wound healing. For non-elective surgery, do not delay the surgery in patients who've recently received therapy. They need to have their surgery. You can't wait around. We don't know that these are bad enough that you need to wait around. And again, avoid restarting them until wound healing is complete. The evidence is not great for this, and there's a systematic review that is not very old from 2022 that seems to refute some of the recommendations that I just gave. There were 133 papers they looked at. They ended up including 11 of them. None of them are RCTs. This is all observational data. But those papers did not show any significant difference in the risk of surgical site infections or delayed wound healing among patients who continued their biologic DMARDs versus those who did not. You can see that on the forest plot there, it is right there in the middle, that it does not favor continuing and does not favor stopping those medications. Also, what it does absolutely show, and not surprisingly, is if you stop someone's biologic DMARDs, their condition will flare. So you know you get the harm of causing their condition to flare. We are not sure that you are getting the benefit of better wound healing. And again, this is from that same systematic review that shows that there is no statistically significant difference between surgical site infections in the two groups who keep their medication going and those who have it stopped. Similar rates of delayed wound healing between the two groups, but not similar rates of disease flare, which is happening in your patients who you are stopping their biologic DMARDs. This is all observational data, reminds us that we need some randomized controlled trials. Generally, the recommendation is to hold them before surgery and to wait until they are all healed up before you start them again about 2 weeks later. How about our checkpoint immunomodulators, our immune checkpoint inhibitors, medications that are now often being given in conjunction with chemotherapy or radiation for our patients who have oncologic disease? The problem with these medications is that the same benefit that causes them to attack the cancer also is the thing that causes them to attack the rest of the body. And so almost all patients who have immune checkpoint inhibitors will have some side effect from having that immune checkpoint inhibitor. Just depends on how much and what part of the body it decides to attack. You can see on that figure there, it can attack anywhere essentially in the body. So your pre-op evaluation should include asking about all the different body parts that those medications could be attacking. Now you can see what happens is that it seems to attack different parts of the body, different number of weeks into therapy. So the earliest issue is with skin and rashes, the dermatitis. You also see some of the GI colitis, enteritis stuff early on as well, probably within the first couple of months. Things that you start to see later are pulmonary and renal, and probably the thing that people worry about the most is the pulmonary problems that people get with these toxicities from these medications. And so think about asking particularly about the pulmonary issues when the patient is getting ready for surgery. Now, these can happen at any time. even after stopping the medications, they can still suddenly get the toxicities from them. So even if they are all done with them, ask about it. And the perioperative concerns seem to say actually that patients do fine with these immune checkpoint inhibitors if you're not finding specific problems when you are doing your evaluation. And that the timing of surgery shouldn't really matter. If they just got their medication, you can still send them to surgery if they need their surgery. And just remember that when they actually do get problems from these medications, they often involve treatment with high-dose steroids or other biologic DMARDs, and you might want to think about how that could impact the perioperative period. And we'll see more of this as the data continues to come out, particularly when you start to combine them with other chemotherapy and XRT. This study came out from our folks at Hopkins with Dr. Faraday as the senior author that indicated that patients tend to generally do well with these when they are getting them in the perioperative setting. Although not statistically significant as the primary outcome, there was a secondary outcome that seemed to show that there was more cardiac instability, particularly patients needed prolonged pressor dependence for those who are on these immune checkpoint inhibitors, but otherwise seemed to do pretty well. And they all got out of the hospital, thank goodness, alive. There was no difference between those who were getting immune checkpoint inhibitors and those who were not in terms of 30-day discharge alive. So the summary is, think about the degree of HPA axis suppression depending on the dose and duration of the glucocorticoids that they've been receiving exogenously. If you are worried, make sure you're going to treat them for adrenal insufficiency by giving them supraphysiologic doses up front. You can continue the non-biologic DMARDs. The biologic DMARDs you should probably hold, although there's not great evidence. And then watch out for all the different things the immune checkpoint inhibitors can do.